please welcome Marissa Moran Gantman, Chief Communications Officer at the Pacific Council on International Policy.
Hi, hello everyone. I'm Marissa Moran, Chief Communications Officer, and today we are bringing you a rapid response dialogue with Dr. Peter Katona about the COVID vaccine that was approved this past week by the FDA and has already started reaching first responders and healthcare workers here in LA and around the country. I am probably not only speaking for myself when I say that emotion really welled up in me when I saw footage of those UPS trucks pulling out of the Pfizer warehouses in Michigan. And I heard that earlier this week, a police escort was seen accompanying trucks carrying the vaccine away from LAX. I know that I would have honked really excitedly and with a lot of joy if I was right on the road there and had seen those myself. The Pacific Council really likes to unpack what we call local to global events and issues, those that have ramifications both at the global policy level and also in local communities. And the pandemic, both from its beginning and its very hopeful end, is a vivid example of a local to global reality that we're all facing right now. I'm happy to introduce today's speaker, Dr. Peter Katona, who is Clinical Professor of Medicine at the David Geffen School of Medicine at UCLA. And he is Adjunct Professor of Public Health at the UCLA Fielding School of Public Health. Dr. Katona has worked at the Centers for Disease Control and Prevention, and he's been a member of the LA County Disaster Coalition Advisory Committee, among many other public health boards. He has authored articles on medical informatics, medical education, influenza, polio, nutrition, bioterrorism, disasters, and the future of healthcare. And on top of all of that, he maintains a private practice in infectious diseases. We'll start with some opening remarks from Dr. Katona, but I'm sure that you all have a lot of burning questions to ask him, so we'll have ample time for Q&A and sufficient time for Q&A after his remarks. And you can submit any questions that you have in the Q&A box at the bottom of your Zoom screen. And now over to Dr. Katona.
Well, thanks, Marissa, and good afternoon to everybody. I'm going to talk about first some alarming numbers, why they're going up, what could be and what isn't being done, all leading up to vaccine distribution. But I want to start with the poll. So let's bring up the poll just to get going here. So the question is, if a COVID-19 vaccine was offered to you today and you had no medical contraindications, would you take it? All right, let's bring up the results. Wow, pretty good. 96% said yes. Better than the average population. We have a highly educated population here. So what we're dealing with is a highly transmissible and deadly pathogen that doesn't respect borders. We have an outbreak that is unusual socioeconomically. Generally, outbreaks like this affect the rich and poor equally. This outbreak seems to be making many of the rich richer and many of the poor poorer, which is very unusual. It's serious enough that California has activated its mass fatality plan, asking for 5,000 additional body bags, while the White House doesn't want to activate the Defense Production Act for vaccine distribution. Globally, we're talking about 75 million cases, 17 million of them in the United States. And if you go down to county level, there were 22,422 new cases yesterday. Think about it, in early October, we're talking about 1,000 cases a day. We've gone up more than 20 times in that time period. So it's been the worst day yet. ICUs are full, and we're nowhere near the Spanish flu numbers of 100 years ago. So why are we having this surge? Well, we talk about COVID fatigue and non-compliance with intermittent adherence to these non-pharmaceutical interventions, this rugged individualism, libertarian kind of nobody tells me what to do kind of thinking. But I'm going to give you 10 additional reasons that people haven't thought of quite as much. And it starts off with number one, global lack of cooperation, which has been prominent. Number two, a rising mistrust in institutions that are working well, with populism, autocracy, politics taking precedence over public health, a lack of compromise, a lack of consistent leadership. Number three, poor and inconsistent public health messaging. Misunderstanding of terms like what no lockdown means, what stay at home means. Not understanding the difference between science and the application of science. Number four, colder weather. This virus loves cold weather and people tend to stay indoors more and puts them at higher risk. Number five, downsizing of the number of hospital beds and personnel, which has been happening over the last decades, with an additional inattention to the needs of public health. Six, inadequate and a maldistribution of testing, with no national plan to really help places that can't get enough testing done. And without that, you can't do very good contact tracing. When Los Angeles County has 20,000 cases a day, contact tracing is virtually impossible to do. We also have number eight, the rising number of young adult infections. These tend to be mild or asymptomatic, and that tends to be a magnifier to other age groups and other risk groups. Nine is strain mutation. There seem to be two predominant strains, a Chinese strain and a European strain, and a lot of substrains, and that's mutating from time to time. And finally, not understanding risk perception and risk tolerance, as all of us are different and our tolerances are different. So where are we in California? Well, we've switched from an all infection demographics kind of thing to medical needs. So instead of looking at test positivity per 100,000, we're looking at 15% or less ICU capacity, which we have far exceeded already and locally. So we have these new orders, stay-at-home orders that pertain to restaurants, gatherings, retail businesses, offices, non-essential travel, hotels. And all of the jurisdictions around us are involved, from city to county to state to the federal government. And LA County, interestingly, has the harshest measures in the country, but these don't compare to what's happening in East Asia, what happened here last summer with curfews and stay-at-home restrictions and travel quarantines. We normally have mutual aid understandings with other jurisdictions. Those are out of the picture now since every jurisdiction is suffering. And there's been this backlash with compliance and enforcements. Sheriffs refuse to enforce ordinances. Businesses are very unhappy. Health officials and doctors are frustrated, and some people are just plain fed up. So that brings us to vaccines, which has been called the light at the end of the tunnel, with a good rollout starting. Moderna will get advisory committee approval today and will be released probably within 24 hours. So what's happened here? It took less than a year, a great achievement, to have 2 safe and effective vaccines with many more in the pipeline. Mass production preceded approval. This was a financial gamble, but is really paying off because it's going to save us many months in getting the vaccine out, with hundreds of millions of doses, starting with the 3 million we're going to get now. I should note, vaccine is going to be free to all Americans. Acceptance by this community was very high, but it's much lower in other communities, especially amongst minorities. But I think this will improve despite the misinformation that's been around. Pfizer and Moderna have a new technology, this messenger RNA technology, that has never been used in a vaccine before. So there are potential surprises. We have cold chain problems, double dosing problems, logistics problems. Okay, so who gets the vaccine? The first tier goes to the vulnerable. Now, healthcare workers are in this category clearly because they deserve it first. And long-term care facility people are also in line. They're in line because their fatality is 6 times higher than the general population, while they only comprise 5% of cases and 38% of deaths. Then we get to the second tier, which won't start until the spring. First responders, teachers, food workers, the elderly, those with chronic medical conditions. And each hospital, and I've been in touch with St. John's Hospital, Cedars, UCLA. Each hospital gets an allotment and prioritizes the distribution. But what about internationally? We have WHO's COVAX initiative, for example, which wants to get the vaccine out to 183 countries currently. The aim is 8 billion doses by the end of 2021. But unfortunately, the US is not there right now, but that could change on January 20th. The UK and Canada have also started vaccinating. Saudi Arabia's health minister got vaccinated today. Brazil announced it will begin vaccinating in February. President-elect Biden is expected to get the vaccine next week. French President Macron just got notice of being infected. But all this hinges on global cooperation, joining WHO and COVAX, avoiding what's called vaccine nationalism, and especially vulnerable are the 75 million displaced population people around the world. But vaccine also generates lots of questions. Does it prevent transmission? Does it prevent asymptomatic illness? What's the duration of immunity? It has a complex logistics associated with it. What about the rare adverse events? But this is going to be less of an issue because there'll be more people vaccinated in a day now than in all the phase 3 studies combined. What about special populations like the young, the pregnant? And what about misconceptions? Herd immunity has been talked about a lot, whether it's natural or vaccine induced. And natural herd immunity has been talked about, especially in the White House, and it has fraught with problems. If indeed we decided to go a route of natural herd immunity, think of what happened 100 years ago with Spanish flu. There were 675,000 US deaths in a population 1/3 of what the population is today. And if you look at what 15% background positivity has done to emergency rooms and ICUs, think of what 60, 70, or 80% will do. It will devastate the healthcare system. So going us toward natural herd immunity, which I can't believe was even discussed, is a very bad idea. What about vaccine certificates enabling you to travel, enter a facility, even see a movie? Are those going to be in the picture? And what about the misinformation dispensers and their influence? What about them? Are they going to be dictating our policy? So what are the possible endpoints with all this? Well, there's disease eradication with vaccine herd immunity. That would be a good thing. There's lack of control where we're going to lead to rationing of healthcare, which we've never, ever done before, or something in between with a controlled low-level infection becoming endemic. So we're going to reach a new post-vaccine normal. We're going to have new bio and information technologies, artificial intelligence, leading us to unprecedented achievements. New therapies will be coming out. But what about words like common good and compromise and moderation? Are these going to become dirty words? Will there be a compromise between socialism or what's in it for me, rugged and libertarian individualism? What about the intentional dissemination of misinformation for somebody's personal or group gain? There will be more and different global outbreaks. What are we doing to address these? So I'll finish off by saying, remember to distance, mask, wash your hands, and avoid crowds, even after you've been vaccinated. It only takes one contact to infect you. And I'll leave it at that.
Thank you, Dr. Katona. You're right, there's so much to think about, not only in our immediate term, but also long-term. How do we get ahead of this in the future? That's a very helpful overview. Thank you so much. We have a couple questions coming in, and as I mentioned earlier, we want to leave plenty of time for all of you to ask your questions. We have quite a few people on the call, and I'm sure that given how truly personal this issue and reality really is for so many of us, we want to give you the opportunity to ask your questions. So let's see, I have one here from, it's just from Anonymous, but Dr. Katona, I think it's referencing when you mentioned that there were 2 strains. This person is asking, are you saying COVID in Europe is not the same disease as COVID USA?
The 2 strains are mixed. We started off with a Chinese strain, and then we went to a European strain, and then we got primarily the European strain, but not entirely the European strain. And these are the big strain variations. There are also lots and lots of substrain variations. And even if you take two people and you actually genotype their two strains, there are going to be slight differences to begin with. So yes, we are subject to all the strains, but primarily we have been subject more to the European strain because the virus went from China to Europe to the United States primarily.
Okay, thank you for that clarification. We have a question here from Rajika Shah asking, can you explain a little further about the mRNA technology used in the Pfizer vaccine? What are some potential risk factors from that technology specifically?
The mRNA technology is fascinating. You know, normally in the past, we've taken other viral vectors, we've taken viruses and made them inactive or made them ameliorated so that they don't produce disease. What this technology does is very different, and it has never been used in a vaccine before. And what it does is it takes a piece of something like computer code. It's a certain portion of the genetic signature of the virus. And it's the signature to produce that spike protein. So what it does is we tell the human cell to produce antibodies against a spike protein. And so the resistance is there before the infection ever starts in natural way. And it's never been used before. It has great potential. There are problems with it because the body can destroy these pieces of genetic code very easily. So they have to be very well protected. And that's one of the reasons we have to do all this cold chain stuff with them to keep them protected. We also have to be careful that it doesn't induce too high an immune response, an autoimmune response. So we have to be very careful at exactly how we dose it. So that gives you some idea of how the vaccine happens and how it's different from previous vaccines.
Thank you. We have a question from Ricardo de la Fuente. My question to you is, do you believe that the companies releasing the vaccine were rushed? For example, if you have a biotech company and $50 billion in funding, you take the funding and then you give the vaccine to the most vulnerable population. If it goes wrong, is that company simply going to blame the government for rushing them and do it again? How would you address the balance between rushing the vaccine or taking the time to evaluate its negative impact?
Well, let me start by saying we have a time of urgency here. We have a dire situation. So you might say, okay, we can cut some corners. But corners, in my view, have not been cut. There are too many safeguards that the FDA does. I've been on an FDA advisory committee, so I know how the process works. And no corners have been cut. The pharmaceutical executives have said no corners are cut. The review panels that are there before the vaccine is actually released are there to constantly monitor what's happening. The advisory committee for Moderna is meeting today. Okay? And all of those things have been taken into account. I have no doubt that this is the same process that goes on for any vaccine. Remember, we have to be very careful about vaccines as opposed to therapeutics. Because therapeutics, you're giving something to someone who is ill to make them better. With a vaccine, you're giving something to someone who is not ill. So you take a greater liability. So you have to be even more careful with a vaccine than you have with an antibiotic or another therapeutic.
Okay, thank you. We have Dawn Hadigi has submitted a couple questions here, so I might just share two of them with you if you don't mind answering back to back. Her first question was, can you shed the virus if you're vaccinated? And if you wouldn't mind explaining what it means to shed the virus for those of us that aren't in the public health space. And also, what is the definition of a healthcare worker? We keep hearing that healthcare workers will be the first ones to receive this. Is it everybody that works in the hospital? For example, even including transporters or those who, drive the ambulance, I suppose, if you could provide some definition around that.
Okay, I think there's going to be, first of all, some discretion from institution to institution at how they make that definition. But in general, what it has in common is the fact that they are having a higher level of exposure. So the people that get the vaccine first are the ones that have the highest level of exposure. This is not just physicians, but it could be respiratory therapists, it could be nurses, it could be the person who cleans the room of the COVID patient. So all of those people, so anybody who is basically at higher risk. Then you have some people that are physicians in the hospital who don't directly see COVID patients, but they are in the vicinity of COVID patients. They may be in the next layer. And some hospitals have defined all physicians as being in the first layer. So it's a matter of how much contact you have with a potential exposure to getting infected. Then we deal with the people who have less exposure. These are the 1A and the 1B category people, and they're going to be next in line. So we suspect that the primary people in healthcare settings are going to be vaccinated by the end of this month, is the projection. Starting in January, there'll be the 1A, 1B people will start to kind of get vaccinated. So that gives you a general gist. Now, in terms of shedding the virus, there's no shedding of something that is inactivated. So if you get vaccinated, you're not getting any virus, you're getting a little tiny piece of genetic code. No worry whatsoever that you're contagious or infectious. So if you get vaccinated, you're not going to be shedding anything.
Okay, thank you. That is actually somewhat related to this next question. Can you expand on how we should behave after we're vaccinated? Would people that are vaccinated still expected to still be expected to wear a mask, to practice social distancing? How would behaviors change? And I imagine we're going to see a divergence between those who are vaccinated and those who are not over the next year. So if you could speak to that.
The recommendation now is, if you are vaccinated, to continue all of these non-pharmaceutical interventions, the masking, the distancing, the crowd avoidance, that kind of thing. Now, your ability to transmit the virus and receive the virus by the value of a mask is certainly going to be different. But the problem is, you don't want to separate people into two different populations. The vaccine is not always going to work. So the recommendation is that anybody who's vaccinated at this time should follow all the same precautions as if they weren't vaccinated.
Okay. All right. That's helpful, I think, for all of us as we think about moving into the future, no matter how soon we as just, regular citizens can get this vaccine. Yahya Samawi has asked, I noticed you had nothing to say about the Chinese vaccine used in the UAE. Would you like to weigh in on that, Dr. Katona?
Well, there's 3 Chinese vaccines and there's 1 Russian vaccine, and I kind of put them all into the same category because the amount of information that has been released has not been enough to satisfy what would be the FDA requirements. So until we see enough information from them to show us that they have met the same standards as we would meet with our approval process, I'm leery about recommending that they be used. They're certainly a propaganda tool. Everybody wants to be the first out with a vaccine, but there's not enough data that the Chinese and the Russians have given us for us to feel comfortable that those vaccines are safe and effective.
Thank you. We have a question from Margaret Traub asking, a recent LA Times editorial highlighted the re-escalating shortages in PPE, particularly gloves and gowns. Do you anticipate this being a growing problem, and what do you feel needs to happen to avert it?
It's going to be a problem, but it's going to be a maldistributed problem. There's institutions that have well prepared for this and have ordered millions and millions of supplies of masks, for example. And they're going to be okay to get through the critical period of the next month or two, which I believe is going to be important. But there are also institutions that didn't prepare for it, or didn't have the financial resources to prepare for it. And that's where a federal initiative would have been very helpful, and hopefully will come with a new administration. But those are the ones that are problematic, and they're usually in poorer communities. So it's important that they get a distribution from some source that is able to see what's going on in the whole country.
Thank you. Do you have any ability to estimate when the entire US population will have been vaccinated?
Well, right now we have about 600 million doses that are in the pipeline somewhere. Some of those doses come from companies that haven't finished phase 3 studies yet. But there's about 600 million. There's an additional 100 million doses that we're negotiating with Pfizer that we could have had, but we decided not to, and now we changed our minds. So we've got many hundreds of millions of doses. Remember, in the mRNA vaccines, you need 2 doses for every successful vaccination. So we have a lot of vaccine coming. So maybe by the middle of the year, we might start getting close to herd immunity. If you're really, really optimistic. By the end of the year, I think I would bet on it.
And so you mentioned these 2 doses. Will we also need to have annual vaccines, or is it understood that you take these 2 doses once in your lifetime and then you're covered?
We don't know the answer to that question. We're kind of assuming, because of precedent and other factors, that maybe it'll be a once-a-year booster. But we don't know that because we don't know how long immunity lasts. We know that immunity from vaccine is probably longer than immunity from natural infection, which is rather unusual compared to other infections. But we think that, so we don't know the answer to your question yet, but the predominant thinking is maybe once a year.
Okay, thank you. Salvador Villar asks, what priority should low-income essential workers have in the distribution of vaccines? And I assume that question is asking maybe where right now, how is that priority falling out for low-income essential workers in particular?
Well, essential workers are in the second tier. So they're going to be vaccinated around January, February at the earliest. But they are definitely ahead of the general population. They're in between healthcare workers with contact with COVID cases, long-term care facility people who have first priority, essential workers, first responders, maybe even teachers will have second priority, and then the general public will come after that.
And can you remind us who is setting that priority at the local level? So for example, in Los Angeles, is it the county or the city?
It's a mishmash. I mean, there is county efforts. County, for example, has advertised that they're sending it to the 3 hospitals in the county system. Harbor, for example, Harbor Hospital. But other hospitals, especially hospital chains, are getting the vaccine. Providence System is getting vaccine to each of its hospitals separately, for example. Cedars, with its hospital chain, is getting its distribution separately. So there's a mishmash. The county technically has jurisdiction over the dissemination of vaccine within the county. But you also have the federal government dispensing it to several hundred sites. You have disseminating it to institutions like the VA or the Department of Defense. So it's a very complicated logistics issue of who gets it and when they get it and what they have to bypass to actually get to the point of distribution.
It's very helpful to think through it from a policy perspective. From AD Rentine, we're asking, what my concern is with the ethical aspects of distribution. Everyone should have the right to vaccination as part of the human right to health. What steps are being taken to ensure that those incarcerated in prisons who cannot avoid exposure, like those in nursing homes, will receive vaccines?
It's a complicated question with no significantly unitary answer. Certainly, these places like Bureau of Prisons is getting a specific allotment of vaccine, as is the VA, as is Department of State, Department of Defense, those kinds of places. But it's going to vary, and as time goes on, each jurisdiction is going to have a little bit more leeway. They're going to get pressure from certain groups to vaccinate me first. So that's going to happen. And I can't predict exactly where it's going to go. But in Los Angeles County, for example, we're talking about LA County Department of Public Health. For global distributions, you're talking about COVAX and its initiative that we are not currently a member of. So it's going to vary from jurisdiction to jurisdiction, and it's going to be a complicated logistical process to get it from place it's manufactured to where it's dispensed.
Dr. Katona, would you mind elaborating just a bit on COVAX, the initiative of the World Health Organization?
It's an initiative that WHO is implementing, and I think it has something like 183 member countries that have said we're in. They want to distribute several billion doses by the end of 2021 to poorer areas. Now, some vaccines are more expensive than other vaccines, and they rely on, for example, the vaccines manufactured. There's one plant in India, for example, that is able to manufacture vaccines at pennies a dose. You know, the AstraZeneca Oxford vaccine is very cheap to produce. You know, that's going to be a factor. You know, these messenger RNA vaccines are a little more expensive. They're maybe $20, $25 a dose to produce. So a lot of this initiative to get it to poorer countries is going to depend on this mass distribution at a very, very cheap cost, and then figuring out a way to distribute it. We're talking about thousands of 747s to deliver the vaccine just in the United States. When you're talking about herd immunity in a global population of 7 billion people, you're talking about a task that has never even come close to being attempted. So that gives you some idea of where COVAX is coming from, but it's a good initiative that we should rejoin as soon as the new administration takes office.
Excellent, thank you. We have a question from an anonymous asker. What do we know about other ingredients or constituents in the vaccines? Do we know who is likely to have an allergic reaction to it, such as someone who has had an allergic reaction to the pneumonia vaccine?
Vaccines are complicated, and they have a lot of things put into them, from preservatives to adjuvants. They're all different. As far as allergic reactions go, we have 4 cases so far with the Pfizer vaccine that have been reported, 2 in England and 2 in Alaska. And this is totally expected. We're talking about tens of thousands very quickly being ramped up to millions of doses. There are going to be allergic reactions. And none of these allergic reactions have been lethal. They've been all survivable. So it's one, and there's going to be more adverse events that are going to come about. It shouldn't make any difference in somebody's perception of risk. If you have a history of a serious allergic condition, you carry an EpiPen, you probably should hold off getting vaccinated, unless you're at extremely high risk. So that's where we are now. We could be in a very different place in a month.
Very useful to know. We have a few questions that are coming in asking about specific populations that when they can expect to get vaccinated. I know that you've covered some of these, but if it's okay if I list off a few of these populations, and maybe you could mention what tier they will be in. Dick Troop is asking, can we predict the approximate time when senior citizens, those over the age of 70 without comorbidities, can reasonably expect to get vaccinated? And then we also had a question about dentists and hygienists, and also those in jails, detention centers, and prisons, which I know came up earlier.
Well, again, it goes back to the tiers that I mentioned before. I prefer the tier of over 65 since I'm 69. But elderly, those with past medical conditions that are important, those come into that 3rd tier before the actual general population does, following those that are first responders and teachers and things like that. So that they fall into that category. Dentists and hygienists are clearly a high-risk group, and they should fall into something in the middle there. I've been asked, and I haven't seen very good answers to what do we do with a medical community that is not primarily hospital-based, because hospital-based people seem to be getting the attention. So I don't have an answer yet to how we're going to address medical offices that don't deal with COVID patients very much, or hygienists or dentists. That's going to come, I think, as additional advisories, unless I've missed them and they've been issued already. But they definitely fall into a group that is ahead of the general population.
Okay, and so moving forward, as the general public, if we want to be able to track these updates, like you said, there could have been an update to the when dentists will receive this even so recently. Where can we be tracking these updates most closely, and where should we be paying attention to?
It's hard for me to answer that question because there are all kinds of places that a little tidbit of information comes out here. Just to look at the demographics of the outbreak, I have to go to half a dozen websites just to kind of get the basic information I want in the format that I want it. So I can't tell you where to go. Certainly the state of California website is going to be helpful. The CDC website is going to be helpful. LA County Department of Public Health website is going to be helpful. So those are probably good places to start. And as they get more knowledgeable, they'll be able to give us more useful information in a format that's easy to digest.
That's good to know. And it seems like that could be a call to action for some sort of centralized clearinghouse, whether it be at the city or county or state level or all of them. That's good to know. And actually, after I had asked that question myself, but then I saw this question came in from Lisa Lauman. What is the process for tracking vaccine delivery and coverage at the local and county level? And how will we know where the gaps are and what patterns of demand and access are? Which I know you really just touched on that. I'm not sure if you want to add anything else.
No, that's an evolving process now. And if I tell you something, it may be very irrelevant in about 5 or 10 minutes.
Wow.
So I can't answer that. I think it's an evolving process. You just have to pick the information as it becomes important, depending on how much time you have in addition to the other things you do with your life.
Thank you. We have another question here from Rajika Shah, who says, thank you, Dr. Katona. You mentioned that the vaccine dose has to be carefully calibrated to ensure that there is not overstimulation of the autoimmune response. Should people with existing autoimmune diseases still take the vaccine? And I will add personally, this is an interesting question to me. I have type 1 diabetes, and I have been in touch with my endocrinologist about what COVID would mean for me and what the vaccine would mean for me. So I'm very interested to hear your response.
Well, I bring up the autoimmune issue because that's been discussed with messenger RNA vaccines. But that has been addressed by the manufacturer, and they've been very careful to calibrate the dose accordingly. That doesn't mean that 1 in 100,000 people who have some autoimmune disease may have an untoward effect. That I can't predict. But it is something that has been talked about with mRNA vaccines. We have not seen it. It was not seen in 100,000 or so people that have been in clinical phase 3 trials. So I'm not too worried about it, but it's just something that's been talked about.
Thank you. Let's see. We have a couple other questions coming in, and we have about 5 minutes left. So last call, if anybody else would like to ask a question. We do have one here about how is the size of the patient related to dosage? Actually, 2 of these came in. I think weight based on your weight, would that affect how many vaccines you need to get?
The short answer is no.
Okay.
Everybody gets the same dose.
Okay. Let's see. There was a question about any thoughts on therapeutics, Cytodin, which has been used as a trial at UCLA and St. John, for example.
Therapeutics are tricky, and if you talk to the people who actually take care of these patients, many of them will say, I don't know what I'm doing because I don't know when these drugs work and how they work and whether they actually work at all. We know that Decadron, the steroid, is effective if given at the right time in the course of the disease. When you talk about antivirals like remdesivir or monoclonal antibodies from Regeneron or Eli Lilly, much more questionable whether they really have efficacy or not. We're looking at that now to see whether they have value. But we're at the early stages, and we could have a breakthrough at some point that would be even as significant as vaccine if something happens and we get a very safe and effective drug that cuts the disease off early. So that's still a potential something that could happen, but it hasn't happened yet. And there are clearly people working on it. There are clearly people doing controlled studies. One of the problems is if something looks promising, then all of a sudden it's really hard to do, controlled, placebo-controlled, double-blinded studies because everybody wants the drug now. So it becomes a bit of a problem, but therapeutics, I think, are very important, and I think they should be high on our list of things that we need to look at.
Thank you. Dr. Katona, we are just about coming up to time here. I wanted to ask if you had any closing remarks to make. I know some of my major takeaways. First, I want to thank you so much for spending this time with us and for taking these questions. You did it with great aplomb. A lot of rapid fire questions coming your way, and you had wonderful answers for all of them, very clarifying answers. So thank you. A few takeaways that I have is that the US joining COVAX would be a really important move, possibly as soon as next month. We know that has become a political issue, maybe where it hasn't been in the past. So that is a promising reality for us as a globally engaged nation. Of course, global engagement is something that Pacific Council believes in very deeply, and our role and leadership in the world, especially when it comes to this pandemic and the vaccine distribution. And also that as individual citizens, we are encouraged to follow, really, it sounds like the CDC or our state website, state of California, or whatever state the folks on this call might be joining us from, to follow how their vaccines will be rolled out. Is there anything else that you'd like to add?
I think one of the more important points that I touched on, which I would really like to stress, is this is not just a disease outbreak. This is an outbreak of mental problems. This is an outbreak of businesses shutting down. There's so many components to this that I think we need to think in terms of amalgamating the economics, the public health, the mental illness. All of these things have to be amalgamated into a reasonable approach that everybody has some input in. You're never going to get universal agreement. You can't convince somebody whose businesses is basically shut down that public health is more important, for example. But at the same time, public health should not be relegated as just another lobbying group. They should have at least prominence to kind of say, if you don't do this, you're going to pay a price in the long run. You might get some benefit in the short run. So that's one thing. And I clearly think that the disadvantaged communities have really become problematic here in not having access to a lot of things. If you're in a disadvantaged community and you're positive, you've got to isolate, but you go into a home where there's 10 other people in 2 bedrooms, where the hell are you going to isolate? So there's this equity socially, economically amongst people is not being adequately addressed. And until we address that, things are not going to improve very quickly.
Thank you. Excellent point, an extremely important one. I do want to thank our audience so much for joining today. This is our final event. This is the Pacific Council's final event of 2020, and we'll be back with more in early January. If you're just tuning in as a guest today, we're very happy to have you with us. Keep an eye on our website for events that you can continue to tune into virtually as we all stay in this state. But there is a lot of hope, especially stemming from our conversation today. And we ask, if you're able, that you consider contributing a donation to the Pacific Council. We're a nonpartisan nonprofit dedicated to global engagement here in Los Angeles and across the West Coast. You can do that at pacificcouncil.org/donate. Thank you everyone so much. Thank you so much, Dr. Katona. I hope everybody has a happy holiday season and a very happy new year.
Thank you.